Welcome to my channel. In this video, I will discuss thrombotic thrombocytopenia. In thrombotic thrombocytopenia, it is a life-threatening thrombotic microangiopathy that is characterized by widespread platelet aggregation and microvascular thrombosis, and this leads to organ ischemia. How this condition develops? It may be acquired, that is, antibody is formed against ADAMTS13 enzyme, and may be inherited, that is, genetic deficiency of ADAMTS13 enzyme. Now, when there is either deficiency of this enzyme or when there is an inhibitor against this enzyme, it leads to accumulation of ultra large von Willebrand factor multimers, and when these multimers are deposited in the body, lead to excessive platelet aggregation and lead to microvascular thrombi formation. There is therefore consumption of the platelets, and platelets are decreased, and also there is hemolysis. Why? Because when RBCs pass through these microthrombi, it leads to shearing on the RBCs and therefore hemolysis of the RBCs, and also there is ischemia because of microvascular thrombi formation. It has clinical pentad, but it is not seen in all the cases. It is seen in almost 25% of the cases. First one is thrombocytopenia. It has petechia and bleeding, that is mucocutaneous bleeding. Second one is microangiopathic hemolytic anemia. As I have told you, when RBCs pass through these microthrombi, then due to shearing of the RBCs, there is microangiopathic hemolytic anemia, and our peripheral smear you will see schistocytes or helmet cells. Next one is neurological symptoms. Neurological symptoms include confusion, stroke, seizures, etc. And acute kidney injury is also seen in case of thrombotic thrombocytopenic purpura, but it is more severe in case of hemolytic uremic syndrome. Also, you will see fever with thrombotic thrombocytopenic purpura. How will you investigate this condition? First, you will do CBC. You will see low platelets and anemia. And on peripheral smear, you will see that there are schistocytes. It means intravascular hemolysis is happening. And also LDH raised that shows hemolysis. The indirect bilirubin is raised because of intravascular hemolysis, and haptoglobin levels are decreased because when there is intravascular hemolysis, hemoglobin binds to this haptoglobin and therefore free haptoglobin levels are decreased. And you will check ADAMTS13 activity. ADAMTS13 activity assay is confirmatory because when there is inhibitor, you can detect the inhibitor, and when there is ADAMTS13 low levels, then it means there is inherited deficiency of ADAMTS13. How will you treat this condition? When you suspect thrombotic thrombocytopenic purpura, you have to start plasmapheresis, plasma exchange, because it is a life-threatening condition and you have to do plasma exchange daily for at least 2 weeks. And corticosteroids should be given also. And you can also use rituximab and caplacizumab. Caplacizumab is a newer agent and it has anti-VWF activities, and it is under trial also. Rituximab and corticosteroids can be used along with plasma exchange mostly. Caplacizumab is an expensive drug and it is not used widely. Avoid platelet transfusions, because when you transfuse platelets, then it leads to further thrombi formation and further microangiopathic hemolytic anemia and further ischemia. Therefore, avoid platelet transfusion in case of TTP, and when plasmapheresis sessions are done, then you can start platelet transfusions. Prognosis. When it is untreated, mortality is very high in thrombotic thrombocytopenic purpura, almost up to 90%, and with treatment, survival is more than 80%. So, when you have a high suspicion of this thrombotic thrombocytopenic purpura, start plasma exchange and give corticosteroids, and you can also give rituximab. Caplacizumab is expensive drug and therefore it is not that much important here.